different numbers mean and what they actually represent. Has anyone heard that, for example, saline's an acidotic fluid? Sodium chloride, it's supposed to be about 38. The closer it gets, the more acidemic you become, or a solution is, which is why saline with a difference of 0 is very acidotic. Plasmolite with a difference of greater than 38 is actually alcoholic. So if you've got someone that's acidemic and you want to make them alcoholemic for whatever reason, you can give them plasmolite and it will work. The other type of fluids is colloids. So colloids basically for us come in albumin 4% and 20%. They'll come as a 500 ml bottle of albumin 4% or as a 100 ml bottle of 20% albumin. Generally won't give them much on the wards, unfortunately. There's not really much difference between them and crystalloids, to be honest, which we'll talk about in a bit. The other ones that are there are synthetic colloids, so the starches. Same as giving 500 mils to the 90-year-old that's in with just degenerative, God knows what, and like they do when they hang out in hospital. Right? So we assume it does the same thing to everybody. What are the problems with it? It doesn't really work in the people you want it to. So people that are hemodynamically unstable don't actually respond to fluid boluses very much. Conversion from high cardiac output states, or low to high rather, doesn't actually, it isn't beneficial for some people. Sepsis is a high cardiac output state. It's not very good though. The physiology of intravenous fluids, we don't really know too well. So what we do know is that if I gave any one of you right now a litre of crystalloid, it'd basically be out of your intravascular space within an hour. There'd be maybe, of the 1 litre, 50 ml left in there. So it's 50 ml out of 5 litres of your cardiac output, assuming you're the 70 kilogram standard man, right, at room temperature. So where does it go? All the other extracellular volume. Where's all the other extracellular volume? All the fluid is in your hands, in your feet, your lungs, your brain, your heart, your kidneys, your gut. So basically all the fluid you give to try and fix a transient number problem ends up going somewhere else to another organ and causing problems later. And the problem is that crystalloids and colloids basically do the same thing. They will both leave the intravascular space very quickly in people that are not actually dehydrated. Right? So unfortunately, it's not like many other drugs. Like if you walk up right now and, I don't know, you gave someone 50 milligrams of intravenous metoprolol, you'd know pretty quickly when their heart rate dropped to like 5 that you were the cause of it and you killed them. However, it's pretty hard to associate stress, right? Because they just think, oh, they're old, they're sick. No one thinks that, in fact, they've basically got somewhere in the order of 3.5 or 3.9 litres sitting now, potentially, in their interstitial space in their lung, which doesn't help for gas exchange, right? So giving fluids is actually really dangerous. We do it all the time. We give it willy-nilly, and I promise you, just as I will probably do it tomorrow when I work, you will do it when you work as well. Someone will badge you about something, and you'll just say, just give them some bloody saline or something, whatever. Give them 5 minutes, right? I know you're going to do it. I'm not going to stop you from doing it, because I'd still do it myself. But at least I want you to be able to think about when sometimes it might not be the right thing to do. So that's the only point of this lecture, to try and work out when sometimes it might not be the right thing to do, even though the numbers have been a pain in the ass, okay? And this is just, whilst we're talking about a fluid challenge and a fluid bolus, what was actually defined as fluid responsiveness, because that's what you've got to look for. It's actually specific to the stroke volume. You have to have a 10 to 15% increase in your stroke volume. What's funny is that the ways that you can assess that we would normally do, heart rate, blood pressure, whether veins are collapsible. Everyone bloody loves the like, you know, jugular vein. Everyone loves it. Oh my god, the JVP's up. Yeah, it's great, right? It's pretty shit. That's the problem. It doesn't really work. Chest X-rays, that's better, isn't it? You can see fluid when someone's overloaded. Maybe doesn't particularly help too much. Lactate doesn't help. Central venous oxygen. Let's say you've got a central lining. Doesn't really help, right? What about some of the dynamic tests? Has everyone ever done a passive leg raise? No, that's actually a way, because if you think all of your volume in your body within your vascular space, right? You've got about 1/4 of it sitting on the arterial side, sort of pre-organs and in organs, and then about maybe 3/4 of it on the venous side. So when we give catecholamines and we give noradrenaline, vasopressors, what we're doing is turning the venous side, that unstressed volume that just acts as a big pull, we're squeezing it, and therefore giving like an extra shot, right? That's what we do when we give vasopressors. Now, if you've got all that stuff sitting there, and it often tends to sit in the legs, a lot of it, what you can do is basically give someone a fluid bolus of maybe up to 10, 15, 20% by lifting their legs up. Which is why when someone's hypertensive, when they're a bit feeling woozy, you lie them on the ground, right? And you lift their legs up, because it gives them a fluid bolus. So that's one way that you can actually assess before you give a fluid challenge, whether or not they're going to be responsive. Now the problem becomes that that's how you assess their responsiveness, but we haven't got a really good way to measure responsiveness. So unfortunately that sucks. But one of the other ways you can measure responsiveness is with ultrasound. You can do an echo, have a look at IVC collapsibility. It's pretty difficult to do. There's a lot of variation, you have to be experienced, and there's not a lot of evidence currently to support it. So unfortunately, it doesn't really work. So, and after all of this, we get right to the end and we say, fine, let's find a person who's fluid responsive. They're going to actually have an increase in their stroke volume if they get fluids. We don't actually know that they need fluids. It doesn't make a difference if you can increase your stroke volume, right? So what you want to be looking for is signs of end organ malperfusion. Now, for the sake of actually not posing a question and giving you no answers, given that's what the whole point of this lecture series is, to give you answers. So these are some of the things that you may well look for in conjunction, okay? So never hang your hat on one and say, lactate's come down, it must mean it's worked. But you can look for all of these things together and see trends. And that's the way that, I mean, we know that blood pressure isn't really a great measure of how much oxygenated blood is getting to an organ. But if you look at blood pressure coupled with someone's conscious state, coupled with the fact that their urine output's decreased, coupled with the fact that they're cool peripherally, it all adds together, right? So use all of these sorts of things as markers together for what's going on, okay? So how do we give fluids? So people don't do this very often. I'm just going to make a quick comment on it. Ideal body weight versus actual body weight versus adjusted body weight. So we care about it a lot in ICU because the size of people's chest and their lungs don't change even if you put 400 kilos outside weight and fat, right? So when you ventilate someone, you sort of need to know what their ideal body weight is because you have to be careful and protect their lungs. Quick way to do it is ideal body weight for a guy is going to be their height minus 100, for a girl's height minus 110. Okay, and that's your ideal body weight. It's what you generally base most things on. We have another one called the adjusted body weight, and the reason we sometimes use that is because if people are really, really, really fat and really above their ideal body weight, then some of the things that we should give will actually go into that fatty tissue, whether it's fluid, whether it's drugs. So sometimes we actually do adjust for as well. Adjusted body weight is basically your actual minus your ideal, and you multiply that by 0.4 and add it to your ideal. Okay? So maintenance fluids. Has anyone seen people write maintenance fluids for surgical patients? Oh my God, it fucking pisses me off so much. Maintenance fluids are not a thing, okay? They don't exist. The only time I will let you write maintenance fluids for someone is if they have absolutely no input whatsoever, and it's a time of day when they probably should be eating or drinking. Then maybe consider maintenance fluids. But who eats and drinks overnight? So why are we putting saline into someone when they do that? Like, they've got an operation in the morning, they're fast overnight. So is everybody when they go to sleep. Why maintenance fluids, okay? We're not talking about like the long-term post-esophagectomy, who for some reason isn't on TPN, so you give them some fluids to tide them over a day or two, right? But we'll get off my soapbox for a second. Unfortunately, you'll have to chart maintenance fluids for people because at the end of the day, it's probably not going to kill most people, and it's pretty easy to do, right? So the way to do it is crystalloid for all your insensible losses, your urine and feces, and albumin for anything that's coming out. And anything that's coming out is basically things out of drains, okay? So the way that you do it, for most people, it's 0.5 ml per kilo per hour of adjusted body weight. So unfortunately, in this case, the fat does soak up into that fluid, okay? So adjusted body weight, 0.5 ml per kilo per hour is your insensible losses, and that you replace with crystalloid. Urine output is easy. You just replace their urine output. Some ways to do it are like look at, say, the last 6 hours if they don't have a catheter in, or when they void, and just replace it, you know, like divide it over 6 and replace it over the next 6 hours, okay? Feces, you probably don't even need to bother adding it unless they've got torrential diarrhea, but otherwise, you don't really need to worry about it. And the other one is drain output. So if people have significant drain output, then you can replace that with albumin, okay? All these slides, by the way, I haven't actually sent them through, but I'll give them all to you afterwards, so you don't have to bother writing anything down if you feel like it's necessary. Hemorrhage is slightly different. It's probably not something that you will have to deal with directly as an intern by yourself, but it's always worth knowing. Basically, I've written up there, do not give fluid bolus therapy unless they're pre-arrest, but it's pretty difficult to decide when someone's pre-arrest, so even when you've got a lot of experience with it. So what I'd say is, get some fluid ready. At most, if someone's actively bleeding and you're giving them fluid, maybe give them a litre, like of crystalloid, and that would be all I would do. And that's as your bridge to getting blood. So basically, if blood is coming out, blood has to go back in, okay? Because we don't have whole blood, we've got red cells, FFP, and platelets. You give that back instead, so those three together, all right? The other one is sepsis. So this is one that you probably treat a little bit more often, especially say in ED or maybe even sometimes on the ward. You probably won't be giving fluid boluses, but it just seems to be more common because everyone's got an infection, right? And people love dumping a lot of fluid into septic patients. It's probably not really a good idea because they haven't really lost fluid. The fluid's still in their body, bar those very few cases where they're actually dehydrated. All of their fluid is still in there. It's just that their vessels are slightly leaky, so maybe it's leaked out a little bit. So maybe they've lost a tiny, tiny bit, and they've lost a lot of that catecholamine response, so they're not actually squeezing the venous compartment properly and giving it, the proper booster preload. So what we normally say is 20 ml per kilo of adjusted body weight is your initial fluid bolus therapy when we're talking about giving someone fluid resuscitation in someone that's septic. All right, and that's for severe sepsis, septic shock, multi-organ dysfunction syndrome, if we're talking about the older criteria, which we'll go through later. All right, so 20 ml per kilo is your first shot. If that doesn't work and their blood pressure is still pretty tanked and they've still got other signs of end organ malperfusion, you can try another 10 ml per kilo. After that, you need vasopressors, right? So that's when you need noradrenaline, for example, or metaraminol you can give peripherally. So normally that basically means that in everyone, about rough ballpark figure, 2 to 3 litres. If you're putting in more than 3 litres of fluid into a person that's got an infection, then it's too much. You're not doing them any good. You're just basically leaking that fluid somewhere else and causing problems for the people on the ward a day down the track. All right? And this was a trial that was done, I'm not sure if you've heard about it and know about it. It was done on kids in Africa in 2011. It's a totally different subpopulation, not necessarily extrapolatable to first world country kids, let alone adults. But what was interesting was they basically had kids that were in septic shock that were brought in, and they were either given a bolus of saline, a crystalloid, a bolus of albumin, a colloid, or no bolus whatsoever. And what actually happened was the kids that got no bolus of fluid when they were in septic shock and hypotensive with evidence of end organ malperfusion, they actually did better in the long term. The kids that got a fluid bolus looked better immediately after, and they died. Okay? And what's being proposed as the idea behind that is that, in fact, the body's natural response of shutting down some organs, we talk about acute renal failure when your kidneys stop making urine. It's sort of like, I think John Myberg uses the term acute renal success, because what they're supposed to do. They're supposed to hold on to fluid. So they're doing it, right? So all of those responses are designed to actually totally give you the best possible chance of fighting an infection. When you do fluid bolus therapy, it overrides some of those. So that's just sort of the word of caution. So we've rushed through that one pretty quick, but basically the take-home messages are that fluids only to be used in resuscitation of hypovolemic patients. So dehydrated, hypovolemic, end organ malperfusion. I caution against writing maintenance fluids, but you'll have a surgeon that wants you to do it and that doesn't understand anything about physiology other than blood comes out when they nick the IVC. But bear in mind that there are ways you can do it and ways that are safer for your patients. Albumin and TBI. So remember that glycocalyx thing before? There was a big trial done, I think back in, could be 2009, the SAFE trial. So there was a meta-analysis before where they looked at albumin, crystalloids, colloids, and there was a big meta-analysis that came out and said colloids kill people. So all of Europe stopped using colloids, put a big ban on them for a little bit. Down in Australia, we actually did a trial, a randomized, controlled, double-blinded trial, where they basically looked at colloids versus crystalloids. Turns out they're not really any different, so you don't get any survival benefit from one or the other. Post hoc analysis, they looked back at some subgroups and they found 2 subgroups in particular. Sepsis, where colloids are better, trending towards being better. Okay, so colloids do better in sepsis. Traumatic brain injury, colloids are worse. And the idea is that with the leaky glycocalyx membrane, the colloids move out. And in most other cases, it doesn't matter where they move. If you've got a traumatically injured brain that now can't keep protein out of it, and you dump protein into it, then you'll cause a mass shift of fluid into the brain tissue. And because it's all in a hard box, you end up getting swelling, increased ICPs, and you die. Okay? So that was the traumatic brain injury. Don't use albumin in traumatic brain injury. Back to that. So, any questions on fluids? Everyone happy about charting fluids? No issues? That was easy. Those seriously coming at 6:30 at night for that fucking talk. Wish I was sitting on YouTube right now instead. Alright. So, why don't we actually do, this was one just ripped from a couple of years ago. So it's basically, what I want you to do, you're the intern that responds to a met call, or a pager. Your pager is going to go off a lot, so get used to it. And so your pager is that there's a pre-met call, it's like a new fancy word, or urgent clinical review, that's the other one, UCR, for someone that's got low stats, all right? So this is what you see when you walk in. Who's going to be up first? Who's going to tell me what's going on? Someone just start talking. You can probably read what's up on the board and I'll get you the rest of the information. So the first thing I want you guys to get used to when you walk in, because it will start making a difference, is I want you to make a really rapid assessment of if someone is well or unwell, okay? Don't care if you're wrong, because you'll get more rights the more experience you get, but you have to identify a well person from an unwell person. Here you've got the advantage of numbers. Is anyone worried about her GCS? No, it's all fine. What about her cardiovascular system? No, it's fine. What about her respiratory system? Yeah, it's a little bit off, right? 89%, 6 liters by nose problem. It's not really that good. She looks like she's actually okay. She's sitting there and she's pretty comfortable, right? We don't care about her abdomen and her kidneys at the moment. So the conclusion is, essentially, this person is a relatively well person. This is someone you probably actually try turning down the oxygen on the nasal prongs, because for all we know, she's probably breathing through her mouth at the moment. Who knows? See what happens, right? Perturb the system, shake it up like I talked about last week, see if it changes anything. But she's well. Now this person, on the other hand, is more unwell, you can tell just because there's more writing on the board, so she's got to be more unwell, right? So who's going to tell me about knowing CO2 retention? What's CO2 retention? Why do we care? Yeah, you can tell me. I'm looking at you right now.
When in like COPD or chronic lung disease,
sure,
they lose their, because they're always trying to have so much effort to breathe, they lose their underlying respiratory drive. Then they hold on to CO2, which then becomes the main thing that's driving their respiration.
And I'm going to expand on that.
They're going to have toxic drive, otherwise the respiratory rate will worsen. If you, for example, if we gave him oxygen as an 88%, it would probably get worse.
And why do we think that?
Because without the CO2, or if he blows up all the CO2, then his respiratory sensors won't tell him to breathe as much. I don't know.
Yeah, so I think that's the common myth that people get taught. Exactly that. Yeah. As a COPD patient, you lose areas of your lung, they don't ventilate properly, so your PaCO2 rises. And that's what drives your respiratory rate. And then when you throw it off by giving someone oxygen, that lowers your CO2, and they don't breathe as much and they die, right? What actually happens is when your area of lung that gets destroyed by emphysema ends up shriveling, all the vessels that normally supply blood to that area of the lung are now supplying blood to an area, and they come in at 75% SATs, which is a venous SATs, and they leave at 75% SATs, right? Because they didn't get oxygen. So they say, well, fuck this for a joke. we won't go here anymore. So the vessel squeezes to get hypoxic pulmonary vasoconstriction. Right? So now what happens is you've reduced your shunt. Because you had more shunt, you had blood that was going through your lungs not getting oxygenated, and it's been reduced. And because it happens so slowly, so chronically, it just slowly happens, and all these vessels close over in areas of lung that aren't working. Now you come along as a well-intending intern, and you see someone that's not like this because this person's unwell, we'll talk about her in a second, but you see someone like the first person back here, who's actually otherwise pretty good, but her SAT's at 88, and you're like, oh wait, no, SATs are supposed to be high normally. So you put a lot of oxygen on, and her SATs go up to 98. You think I'm doing really well for the patient. What's happening now is you're giving oxygen down into those lungs. Those areas of lung that don't actually do gas exchange very well still get full of oxygen. And the vessels there detect that and say, oh, there's a lot of oxygen here, I'll swell up again. But they don't actually exchange gas very well. So they swell up, blood goes through there, but they still don't get gas anymore. They don't get oxygen. So you reverse the hypoxic pulmonary vasoconstriction. And you send someone from having a somewhat balanced lung into essentially a stage where you can't really rescue them with more oxygen therapy because you're just increasing the shunts every time you give more. So that's why we leave our oxygen SATs on CO2 retainers between 88 to 92. Okay, that's a theory behind it. It doesn't really happen that badly that quickly, but that's a theory. Okay, but this person's unwell. All right. So we'll talk about acute respiratory failure just for a moment. Type 1, type 2. Type 1 is low oxygen, type 2 is high CO2, right? Cool. The immediate threat to this person back here, it is somewhat her respiratory drive because she's going to tire very soon with all the accessory muscle usage, tracheal tug, increased work of breathing, tachypnea. But the real immediate threat is the hypoxia, right? Your oxygen's too low, your tissues don't get oxygen and you die. It's not a good thing. So you got to fix it quick. ABC, sure, it's a great way to go about doing things. It's a good way to set yourself up and make sure you don't miss anything. Airway in this person, not really a problem. Remember, at a met call, the thing that's going to make you a good intern versus one of the many others is not whether you actually intubate someone on a met call. It's whether you were somewhat in the back of your mind prepared for that as a possibility, right? So if we come to a met call as the ICU met team and see this person here, and you've already started oxygen, and you've already asked someone, do we have a difficult airway trolley on the ward? Right? That's all you need to ask. If you ask that question, then I'm happy because you were thinking about it, right? Now this was a CO2, COPD patient, so you can get bronchodilators. Nebulizers versus the MDI, the spacers. Spacers are always better if you can get them to use it. COPD, asthma, all that sort of stuff. In sick people, they put the little stuff in and it just nebulizes it and sends it through. It's not as effective as a weight-per-weight thing, but it'll do the job. All right. Steroids, hemodynamics, all that sort of stuff. Specifically, salbutamol, ipratropium, or atropine, they're always good. IV hydrocort, that's a steroid you want to use when they can't take an oral prednisolone tablet. Like I said, if you've already started to organise the next steps, urgent airway management, extra access, you can try non-invasive, then you're doing well, okay? So about this one, you're walking past the ward and somebody sort of says, oh, quick, someone's having an asthma attack, right? It's actually not that uncommon. So you've got a 21-year-old that's admitted with appendicitis, as is up there. Does she look well or not well?
Not well.
Not well. Why?
Tachycardic, hypertensive, speaking in short sentences. She's sort of taken up of normal posturing and shows a audible wheeze.
Yeah, good, right? It's not really hard. Like someone that's asthmatic and is taking up abnormal posturing probably isn't very well, right? How do you treat asthma, acute asthmatic attack?
Bronchodilators.
Cool. What else?
You give steroids as well.
Yeah.
With their posturing.
Good. How would you give them?
So sit them upright, I guess. If they're starting to lose consciousness or something, you can lie them down to try to maintain blood pressure.
Yep. How would you give steroids?
She's young, you could consider like a pred syrup, but probably IV, or would you go and have?
Yeah, so you give IV, hydrocortisone, or you give oral steroids, oral prednisolone, right? Salbutamol, like we talked about, through the nebulizer, if they're working, if they can't stop to take those big breaths in. Often what you find is with some younger people, they do get asthma, they will sometimes get a bit anxious as well. So giving them a bit of time to actually use the spacer and the little puffer thing actually helps to calm them down a little bit, which can be sometimes driving it. Sometimes they just aren't well and you need to give them an actual nebulizer, right? There's asthma severity scales, it's all crap. Just, if they look unwell and they've got asthma, then you should be worried, okay? The really bad ones, I'm not sure if they actually do one here. Yeah, the really bad ones are like this, right? When you go and you see someone and they're a little bit like drowsy, and you'll always convince yourself, oh, they're drowsy if it's 1 o'clock in the morning, right? They're tired, they're supposed to be tired. And then you see them and they're sort of like, they're taking like little short breaths, and you listen, like, there's actually not much wheeze. Like, it's not too bad. I thought they were asthmatic, like, it's not that bad at all. Minimal abdominal wall movement. When the SATs start to drop in a young person, that's when you should start getting worried, because SATs don't drop in young people. So SATs stay high all the time. In an asthmatic, when they drop, that's like pre-arrest. All right? Same sort of thing. Treatment is, here we've decided that despite the fact she's pre-arrest, you can use a spacer. Lots of puffs of salbutamol. If you're going to be using one of the nebulizers, in reality, you just pour it in like the salbutamol, just keep going with salbutamol, atropine together, just continually. All right? If they're that unwell that they need all that stuff, you just do it continually. Steroids, if they're young or if they're serious, intravenous magnesium is your next escalation step. Intravenous salbutamol is an escalation step after that. Aminophylline, theophylline, you give those as well. So it's always worth having in the back of your mind, though you often don't get to them on the met cause on the things you're worried about, but having in the back of your mind what the next escalation steps are, right? All right, so what about this? How bad's her asthma?
Yes.
Why is that up?
There's a few features which are typical asthma, like hoarse voice, rash, and just driving.
What does that make you think of?
Anaphylaxis.
Good, good. So I actually did this to someone in internship in like a short stay area. Sent someone out to short stay while I was in ED, and she was in pain from acute, like a non-acute abdomen, but abdominal problems, awaiting a surgery review. They gave her some morphine. I know it was the first time she ever had morphine, not allergic to anything though. And within seconds, she started like saying, oh, my arm's really itchy. And she was scratching, and this rash just blew up all over her arm, started coming up over her chest. And of course, she looked down and she shut herself about as much as I did, right? So this does happen, and it does happen really quick. How do you treat anaphylaxis? Yeah, how much? I should start throwing these out. You guys answer the questions. Keep going. How much? How much adrenaline do you give?
10 milligrams.
10 milligrams is a lot of adrenaline. Definitely a lot of adrenaline.
1 milligram.
1 milligram is still also a lot.
500 micrograms.
500 micrograms. Okay. 500 mics of adrenaline. Okay. Don't use intravenous adrenaline. It's dangerous. It causes significant arrhythmias. Leave it to an adrenaline infusion afterwards. 500 milligrams, IM adrenaline. Where's it go? into your arse, into the thigh, into the shoulder, anywhere that's not in a vein that's in a good perfusing muscle. Okay, so not fat tissue, doesn't work very well as a subcutaneous in the muscle. Right? What else do you give?
Fluids.
Fluids, yeah, if they're hypertensive, yeah. What else?
Steroids.
Steroids, good. How much? And of what?
Oral prednisolone.
Sorry?
Oral
No, they can't
prednisolone.
take oral pred. What else? What did we talk about before? Hydrocort, good. Geez, you guys are getting that. Over that side, how much hydrocort do you give? It's got to roll off your tongue. 250 milligrams intravenous hydrocort. Yeah, what else can you give? After steroids. So you've given adrenaline, you've given steroids. What's the third thing you give? It doesn't really do much, but you give it.
Antihistamine.
Antihistamine, good. Anyone have any antihistamines they like to use? Doesn't really matter because they don't work. But you can give whatever you want, right? We were talking about, blah, 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 blah. Inhaled adrenaline. Oh, yeah, I wouldn't really do that. IV access is a big one because you know where this is going, right? Tear you down the shitter, quick. How often can you give adrenaline? Oh, damn, I just put it there, quick. How often can you give adrenaline? So you give adrenaline, IM, and then you stand there for a certain amount of time, and it doesn't seem to be working. When do you give it again?
10.
Less.
3 to 5 minutes.
3 to 5, good. Okay, this is going to really test how far these things fly. Catch. 3 to 5 minutes, right? IM adrenaline, give it again. If it doesn't work, you maybe give it again. By this stage, hopefully someone is there to help you, right? That's when they might need intravenous adrenaline as an infusion. What else? I think that's probably about it for anaphylaxis. You should have, the big thing is, if they look unwell and if you're worried, give them IM adrenaline. It's an EpiPen, right? Just give it to them, it's fine. Because steroids help with the rebound, so you get the 2 phases, the acute phase and then 4 to 6 hours later the rebound. That's what the steroids help with. The antihistamines are just there because they're part of our archaic management stuff, right? Easily.
Just out of interest, will ED departments, will they have EpiPens lying around, or would it be
You have to draw up
adrenaline?
So adrenaline comes in generally 1 milligram vials in about, I think it's normally 1 ml of solution. So you'll have to draw up the 1 milligram, dilute it with 9 ml of saline, because that's what you dilute with. So then you've got 1 milligram in 10 ml. Then you basically take that amount, the 5 ml, and you give that. That's a bit unfair, 5 ml into a muscle that hurt a lot. So you can sometimes, if you're really happy, draw about 1 milligram that's in a ml into a small 1 ml syringe, and actually just get rid of 500 mics and then jab that in. And then it's a small dose. But yes, you have to unfortunately draw out yourself. So tachypnea, oh god damn it, this, you will get so many people, because you know how narrow those bloody ranges are for like respiratory rate? Like a respiratory rate of 18 is high or something, right? So you're gonna have to deal with this a lot. So what does this person look like? Who's happy to just alter the net criteria? Review in an hour, hand over, something like that. What are the things that are concerning?
A rate of 125 and 81-year-old.
Yep, good. That's not normal.
It's very hypertensive.
Yeah, she's very hypertensive. That's true. What else?
Got stats with those graphs.
The SATs with the creps. Explain a bit more.
So she has low stats.
Yeah, good.
And she also has coarse creps bilaterally, which isn't normal.
Good. So what are you thinking of at the moment?
She's got probably fluid in her lungs.
Good. So what's that called?
APO, acute pulmonary edema.
Good.
Pulmonary edema.
Good. Pulmonary edema. What types of pulmonary edema are there? And don't say acute and chronic, I don't like that. 2 types of pulmonary edema, acute pulmonary edema. One presents like this. This is the most common type of acute pulmonary edema you will see. Some people call it SCAPE, sympathetic crashing acute pulmonary edema. SCAPE, so edema's got an E for the Americans, right? But it's SCAPO as an acronym. So SCAPE is one. The other one that presents, I'm not sure if we do it, so we'll talk about it, is similar presentation from a respiratory point of view, but you're either bradycardic or normocardic, and you're hypotensive, or maybe mildly normotensive. And that's cardiogenic shock, right? So the whole point of pulmonary edema is, except for the neurogenic pulmonary edema, which we'll leave alone. So cardiogenic pulmonary edemas, the left ventricle is trying to work and it can't do it properly. It gets backlogged through the pulmonary system and leaks out. Starting from before, the starting forces, hydrostatic pressure, increasing the vessels, pushes fluid out. Right? In SCAPE, what happens is, for whatever reason, whether it's like this person with aortic stenosis that's really severe, or whether it's some sort of transient outflow obstruction, what you get is somewhat of an outflow obstruction. The heart gets the message, oh crap, I'm not pumping hard enough. So the body releases a whole bunch of catecholamines. Right? So flooded with noradrenaline, adrenaline, what does it do? It increases your heart rate, and it also tries to increase your blood pressure. It's a vasoconstrict. Now the problem at the moment is that you're too vasoconstricted. So you vasoconstrict, your heart says, oh shit, I'm under more pressure. So what does it do? It tells your brain, what does your brain do? Release more catecholamines. And you quickly see how you get a bit of a vicious cycle, and your left ventricle doesn't do what it's supposed to. And so it pushes blood backwards. The alternative is cardiogenic shock, systolic heart failure, whatever you want to call it, right? Where the heart just cannot physically pump, it's too weak, which is why they're normotensive or hypotensive with a similar thing. It's just too weak to pump what's coming in. So it fills up and just can't do it, right? The reason you have to highlight those is because they've got two very different underlying causes and two very different ways of managing them. So how do you manage acute pulmonary edema? And the chances are whatever management you're thinking of is probably the management for the most common one anyway. So I'll bear in mind the fact that you might not remember the two of them until a few minutes ago.
Diuretics.
Diuretics. Glad someone mentioned that. It's useless. It's really shit. So what's the problem? What did we just explain was the problem with acute pulmonary edema? Have you got too much fluid on board? No, it's a pump problem, right? The pump is not working properly. It's either blocked in front of it, and so it's backlogging, or the pump is failing. So what you want to do is either unblock what's in front of it, or help the pump work faster and better, right? Some people might argue that furosemide does work. The argument they might use is that it does have a small pulmonary vasodilatory effect. That's great. It doesn't work, right? It makes you feel better that you're getting rid of fluid, but you're just getting rid of fluid that's in their vessels. It's not the fluid that's a problem. The fluid that's a problem is in their interstitial space in their lungs. Anyone else? What else can you do for acute pulmonary edema?
GTN.
GTN, good. Why GTN?
It's going to vasodilate.
Yeah, exactly, right? It's an arterial vasodilator, as well as venous. How much GTN? Patch, sublingual. How much is that? Should know this from your STEMI, like acute coronary syndromes. What's a sublingual GTN tablet?
15.
No, multiply it by 20. Yeah, 300 mics. Cool. 300 mics, sublingual GTN. But that's only as your backup while someone's actually preparing an intravenous GTN infusion. Because they need a lot of GTN. Okay? The way that, now again, because we're talking about your met call scenario, or when you get there and someone has really underplayed the situation, you need to call a met call. So the stuff you do is you can give them sublingual GTN. You can ask someone to go and get GTN made up and to bring a pump in. And you can ask someone to get non-invasive ventilation ready. Anyone seen non-invasive ventilation before? Mask that you basically strap onto someone like one of those helm sort of things, and it just pushes air in, right? So what's it doing? It's increasing the pressure in the alveoli, which in turn increases the interstitial pressure. So before, where you had hydrostatic pressures in the veins that are becoming too high, and then pushing fluid into the interstitium, now you're getting the hydrostatic pressures in here becoming high to try and push fluid back, right? That's all you're effectively doing by giving PEEP, positive end expiratory pressure. By the way, if I say things, if I use acronyms that you're not aware of, you want to explain things more, by all means ask, right?
So are those available on the ward? Like,
Non-invasive machines?
yeah.
No, so certain wards will have them. Some wards may have access to them, but only like as a quick way of buying you time. But most, no.
So if someone needs that, that's an ICU thing.
Yeah, or certain HDUs, like respiratory HDU, or whatever. But as in, it'll still be done through probably a med call.
And is that similar? So like I see this between anesthetics a lot, like the OptiFlow. Is that like a similar sort of mechanism to keep it? Like it's this machine they keep bringing around in theatre.
The OptiFlow.
Yeah, like it's like continuous high flow. Like
Yeah,
intubations.
the high flow stuff is somewhat different. So with high flows and the stuff that's attached to like nasal prongs that just sits under there, that helps with oxygen delivery. So that's really good for pre-oxygenation. But it's not as good for positive pressure ventilation because all you have to do is open your mouth and pressure can disappear out through there. Whereas the mask just gets stuck on like that. Yeah. What else? These are all bonus points, trying to look for a reason why they've gone into APO, always helps. But resuscitate first, you can differentiate afterwards. All right. What's this? This could be a cardiogenic shock. Same picture, won't bother reading through because you talked about it. Hypotensive, relatively normal heart rate. Yeah? So in this case, it's a PE. So unfortunately, one of the criteria is up there, so I can't ask you about the Wells score for PE, which stratifies low risk, moderate risk, high risk. Anyone heard of the PERC criteria? PE rule-out criteria? Anyone know what they are? Basically the same as Wells criteria, fundamentally. So the benefit of the PERC rule is if someone is PERC negative, so you've gone through the list of about 6 criteria, and they don't fulfill any one of them, you don't have to look for a PE. And the reason that's important is not for someone like this that obviously has a PE per se, but for the people that are not obvious, you'll find that if you ask the question, someone will ask you to look for it. And if you don't have a really good reason to not look for it, then you're condemning yourself to do a CTPA, which is a CT with intravenous contrast that goes into pulmonary arteries. So you're now going to irradiate someone's chest, and you're going to give them contrast, which they might have a reaction to that you don't know about, and it takes time, and you might even anticoagulate someone in the meantime just in case. So a whole lot of extra stuff that happens because you've mentioned the word P. It's fine to mention it, but there are some criteria you can use to try and work out if it's important, if it's likely or not. Yeah? Treatment, no, whatever. It's the same sort of stuff. Someone's got a PE, you're in trouble. If it's a huge PE like that, you're in trouble, right? I think the only things you can do is probably recognize it early. Yeah, sure. All the other stuff about, obviously treatment options, what you're supposed to do what you can, give fluid, get access. If you want to run a quick history to prepare someone for thrombolysis, ask them about previous intracranial events, about malignancies, about big surgeries, bleeding diaphyses, things like that, just as a quick screen. That's about all you can do. Fever. Oh, you've got a lot of pages about fever. Stop name, who's got a fever? What are you going to do? Are we happy this person as well? What are you going to do? Someone in the back row, because you guys don't want to talk tonight. Someone in the back row, tell me, what are you going to do? I'm the nurse, I'm asking you. This person is 71 years old, he's post-op. He's post-op now, day 1 with a right total knee replacement. He's got a temperature of 38.1. What's your plan? No plan? How many weeks out? Do you care? You can tell me if you don't care, that's fine, that's a plan.
Post-op is probably the game, maybe.
Why?
It's just a surgery.
So it's too soon. Too soon for what? Fair. Could be too soon for any infection, or if they had an infection before they came in.
Pre-existing infection, like community acquired one, is possible. It's relatively stable, so I'm not too worried. Check his bloods, that's what I'll do next.
Yeah, his bloods are normal. The bloods are done in the morning were all normal. And he's got a hemoglobin drop because he also bleed everybody, but otherwise, white cells are fine.
I'm not too worried.
So what are you going to do?
Probably just keep.
You're going to do blood cultures? Going to give antibiotics?
Yeah.
So the nurses check in 4 hours.
Their next set of obs? Yeah, probably fair. Fine. So, why does he have a fever? We still haven't explained it.
It's just like surgery, and it's probably become raised inflammatory markers from the surgery as well.
Do we have a medical name for that?
Yes, but I don't know what it is.
Anyone?
Post-op fever.
Post-op fever. Right, cool. Anything else that sounds more medical? Anyone heard of SIRS? Systemic inflammatory response syndrome? You're not on the end there. What are the 4 criteria for SIRS? One of them is what the Met calls about. Fever, right? So, what is SIRS? So the idea of SIRS is it's used to do what it says on the box, define any sort of systemic inflammatory response. It's a conglomerate of 4 criteria: fever, white cells up or down, or problems with which white cells are there, heart rate, which is slightly on the higher end of normal, and respiratory rate. Or if you get a gas, a low CO2, that shows they've got fast respiratory rate. Okay. Now the key thing is that it's all well and good to say that they look well, but an elective post-op that comes in day 1 could have been unwell before. No one's going to do blood cultures on a person, okay? So unless they've got other symptoms, I'm not arguing at all. No one will do blood cultures. No one's going to give antibiotics. They've already had their cefazolin, for prophylaxis for 3 days, for 3 shots. That's fine. But be aware of why you're saying no. So why you're saying no is not just because I feel like this person looks all right. Because people look all right right up until they die, okay? Why you're saying no is because you've got a really good cause why this person has an inflammatory response. It's because someone just took their knee out and put a new metal one in, right? So the only, this is not for people that are post-op, okay? So fever of unknown origin with no other symptoms is something you have to be careful of if they present in ED, right? Not really necessarily if it's something that happens with an obvious cause as to why they should have a fever. But just be aware, have a low threshold for doing investigations if someone comes in with a fever, all right? Especially if they're rigor. So if someone has confirmed rigors as opposed to chills, a chill is just like, oh, I think I'm getting a bit cold, you pull a blanket up and then you get sweats afterwards, right? Because you're getting the fever, your body's making you move to increase your temperature, and then you sweat it off when it hits whatever mark it wants to. A rigor is when people talk about teeth chattering, uncontrollable shaking, they've got 5 layers on, under an electric blanket with a hot water bottle on their head and they're still freezing. That's a rigor. When someone's rigoring, there's associations with very high rates of bacteremia. So if someone's rigoring, they need multiple blood cultures, they need admission until they stop, and antibiotics. All right? Chills versus rigors, often missed and underplayed. Now, what was this one? That's this 68-year-old book. Is this person well or not well?
Not well, no.
Not well, good. Probably shouldn't be on water, right? What are some of the general prevailing themes of issues at the moment that we see?
Hypotensive.
Good.
So she's septic, with septic shock.
Could be, yeah. Why else? What makes you think that?
Peripheral shutdown.
Yeah.
And tachycardic and hypertensive.
Yeah. What else?
Conscious state's a bit down. She's
Yep.
not responding appropriately.
Yeah. What else? Yep. What else?
It's very acidotic.
What's the difference between acidosis and acidemia? Anyone? Difference between acidosis and acidemia?
Process.
Yeah, exactly. That's exactly it. So acidosis is a process, right? Acidemia is what's in your blood. So the only reason I say that is because there'll be some punctilious asshole like me that sits here and says, actually, they're not acidotic, they're acidemic, right? They've got a pH that's low, so they're acidemic. The reason they're acidemic is because they've got a lactic acidosis, right? Same shit, but you're right. Acid-based problem at the moment. Why do you think it's sepsis? Also because this person got a needle in pneumonia, right? Cool. So they're happy with it. This person's really unwell. Surprise, surprise. So sepsis criteria, this is a bit of a relic of an older age, and by older I mean like a year ago. These are no longer the criteria that are used. There's a new sepsis collaborative that's been put together, new guidelines about what sepsis is, but people still use this all the time because we know what it is. It works. It works to stratify people, and all our studies are based off these criteria, right? So basically, you start with SIRS, and then you get a suspected or a confirmed source infection, and then you're septic. And then you get what's defined as or in this case they call organ dysfunction, hypotension, or a lactate above number X. You're in severe sepsis. And then you go to septic shock after that when you try giving the fluids. Remember those 20 ml per kilo and 10 ml per kilo adjusted body weight boluses we talked about? You give those and they don't work, then you're in septic shock. Then you go down to MODS, multi-organ dysfunction syndrome, which is when the rails fall off, everything stops working, right? Bacteremia is not sepsis, so people sometimes, just for what it's worth, if you have bacteria in the blood, you don't necessarily have to be septic, right? Infective endocarditis will give you a bacteremia for a long time, but you're not necessarily presenting with any of these conglomerate of symptoms, right? The reason that we stratify this and the reason why we still do is because a lot of the stuff like early goal-directed therapy by Manny Rivers, all the early, like get antibiotics in early, give vasopressors, give fluids, is all based on people that fall in the criteria of severe sepsis, septic shock, or MODS. So if someone is septic, it sounds bad, but it's not actually that bad. That just means like I've kicked you in the shin, so you're tachycardic and you're breathing a bit quick and you have a cough. That's sepsis, right? Because I think you've got an infection. Yeah? So just be aware that sepsis per se doesn't mean you have to dive in with the antibiotics and go, all right? Early goal-directed therapy, we're going to talk about it. Basically this is when they used to give people like 6 to 8 litres of fluids just like on spec because you're septic and get a central line and do all these crazy measures and it doesn't do anything. Antibiotics, so we will talk about antibiotics. I got a message from Michael who said, the guy I've been talking to, who said that you guys still want to talk about antibiotics and talk about analgesia. So we'll do that a bit more next week. We can talk about some of the more common antibiotics that you tend to give and talk about analgesia, I guess. Otherwise, dealing with someone that sick is just knowing to call and get them to ICU. You can do bloods, you can get some form of antibiotics in, whatever it is you choose at the time. I don't really care, broad's fine. You can give fluid, you can give steroids, and then basically I just need to get better. And I think that's basically it for that one as well. Any questions at all so far? Yeah.
Would the stage of patient actually go to develop septic shock, or is it just like, I've already heard of it, I don't know what it actually is.
What SIRS is?
Yeah, like do a proportion of patients, are they at a greater risk of developing septic shock?
So the idea is it was used as a screening tool to try and find people before they get to sepsis, severe sepsis, septic shock, MODS. So it's sort of like a quasi-screening tool. The problem is that SIRS in itself, like you said, if I kick you in the shin, you'll be tachycardic and you'll be breathing fast. You technically fit SIRS criteria, right? Doesn't mean now that you have to start antis, look for source of infection, blah, blah, blah. So it's very sensitive, captures almost every infection that people will have if you fulfill those criteria. It's not necessarily specific, okay? Questions or concerns about next year? Things that you've seen and scared you?
Oh, like a really quick thing.
Yep.
With the fluids
Yep.
from the lecture before. You said one of the things we can look at to see if fluids are working is the choline lactate.
Yep.
What if you're giving Ringer's lactate or Huntington's, which is like full of lactate?
Yeah, so it doesn't actually increase your serum lactate that much. So you don't get people that develop like a lactic acidosis because you're giving them CSL. So
it just doesn't get into the actual symptoms.
well, it does, but it doesn't get into it that much that it actually affects your serum lactate so much so that you can then say, you're not sure if you're treating it properly, but it's because it's CSL, if that makes sense.
Yeah, otherwise too.
Yeah. Anything else? All good? All right. I think next week we'll talk about arrhythmias, bradyarrhythmias, tachyarrhythmias, how to deal with them at net calls, antibiotics, analgesia. Anything else that you guys want to go over?
Have a think.
Sorry?
I'll have a think.
Let me know. Whatever. I don't mind. All right.
Thanks.
Yeah. There'll be things that scare you next year, and you won't know about it until they come. So, unfortunately, it's not much help. But yeah, that's it.
Thank you.
Thank you. No problem.